So hi guys, welcome to today's session. Today we are here to talk about the episode 2 of Talking QBank, and today we are going to discuss few MCQs related to esophagus. Now the whole concept regarding this is we are taking up one particular topic and we are discussing the MCQs which are related to it. So I hope you watched my previous session. So yesterday I took a Talking QBank on the sutures, in which I covered pretty much like the many of the important topics, and yeah, today we are going to talk about the esophagus. Now again, in half an hour I cannot discuss the entire esophagus, but I'll try my level best to discuss whatever the topic I take up. I'll try my level best to discuss most of the points regarding that particular topic. Now without wasting any further time, let's start with the first question. So guys, the first question which I have for you guys today is this. What is the first question which I have? All of the following statements regarding the Zenkus diverticulum are true except. So which of these statements is not true? Okay, which of these particular statements regarding the Zenkus diverticulum is not true? Is it like acquired diverticulum? Okay, I'll just kind of move outside of this particular field. So yeah, all of the following statements regarding the Zenkus diverticulum are the true except acquired diverticulum. Lateral X-ray on the barium swallow is often diagnostic. Is it a false diverticulum or outpouching of the anterior pharyngeal wall just above the cricopharyngeus muscle? So what do you think, guys? What is the answer over here? Now guys, please understand, the answer to this particular question is in fact option number 4, like option number D. If you're saying that the answer is D, you're absolutely correct. Okay, so it is not. Here it should not be anterior. What should be over here? It should be posterior. Okay, so it should be a posterior. Okay, I hope you get this particular point. Now let us talk about this in detail. So let us kind of discuss Zenkus diverticulum in detail. So I'll just come back into the frame, guys. So yeah, let's kind of discuss your Zenkus diverticulum in kind of detail. Now what do you understand by Zenkus diverticulum, guys? Zenkus diverticulum, now it is very important topic. Okay, it is very important topic as far as your NEET PG exam is concerned. Now what exactly is happening in the Zenkus diverticulum? There is inferior constrictor muscle. Okay, there is an inferior constrictor muscle. Now this inferior constrictor muscle, this is formed by the two groups. So what are the two muscles which are kind of present over here? So you have your cricopharyngeus muscle and then you have your thyropharyngeus muscle. Okay, so you have your cricopharyngeus and you have your thyropharyngeus muscle. Now what you need to appreciate is that this is your thyropharyngeus and this is what is your cricopharyngeus. Now what you need to understand over here is that both of these are the component of your inferior constrictor. Okay, so inferior constrictor consisting of a thyropharyngeus and the cricopharyngeus. Another thing which you need to consider over here is that the nerve supply. Okay, so you need to consider the nerve supply. The nerve supply of a thyropharyngeus is different and the nerve supply of your cricopharyngeus muscle is separate. So now can you understand this particular point? There is one sphincter which is consisting of two muscles and both these muscles are supplied by the different nerve supply. So obviously there is a point where neuromuscular incoordination can happen. Okay, so neuromuscular incoordination can happen. Now what do I mean by this neuromuscular incoordination? This means that when this cricopharyngeus muscle is supposed to kind of dilate, it is not dilating. Okay, so it is not dilating. If at all this neuromuscular incoordination is happening, what is going to happen? There is going to be an increased intraluminal pressure. And because there is an increased intraluminal pressure, what is going to happen? Patients can develop a pulsion diverticulum. So what can happen? The patients can develop a pulsion diverticulum. Are you able to understand this point? So this is what is your mechanism of formation of your Zenkus diverticulum. So what is happening over here? Because of neuromuscular incoordination, there is an increased intraluminal pressure. Because of this, the mucosa is popping out from this triangular portion. This triangular portion is called as your Killian's triangle. From this Killian's triangle, the mucosa is kind of popping out, and because this mucosa is popping out, this is what is called as your pulsion diverticulum. Are you able to understand this point? So as you can see now, the Zenkus diverticulum is a false diverticulum. Why? Because it is consisting only of the mucosa. It doesn't contain of all the layers of the intestine. I hope you get this particular point. So this is the pathogenesis which we just saw for your Zenkus diverticulum. Now in the next point, what we will see, how will the patient of a Zenkus diverticulum present to you? So what will be the clinical features of the patient, guys? What will be the clinical features of the patient? Now what is happening in the Zenkus diverticulum? You have this particular esophagus, and then there is an outpouching of the esophagus. Okay, so there is an outpouching of the esophagus. So what is happening? Whatever the food the patient is eating, the food is going down, but at the same time some amount of this food is also going into this diverticulum, and it is kind of accumulating over here. And over a period of time, what is going to happen? This partially digested food is going to be present in this particular diverticulum over here. In this particular diverticulum, it is going to be present over here, and because of this, what the patient will develop? The patient will develop halitosis. Okay, so patients will develop halitosis, that is your bad odor. The patients will develop bad odor. Okay, then patients will have regurgitation. The patients will have kind of your pneumonitis, and the patient may also develop lung abscess. Now please understand, this is a very important MCQ which you definitely need to remember, that what is the most common complication of a Zenkus diverticulum? The most common complication which you develop in the Zenkus diverticulum is this lung abscess. Okay, please understand this, please remember this. The most common complication which is occurring in the Zenkus diverticulum, it is the lung abscess. Now let us talk about the diagnosis. So how will you diagnose these particular patients? The investigation of choice to diagnose your Zenkus diverticulum is, yes, you, can you please tell me what is the investigation of choice? It is barium swallow. It is a barium swallow. So you have to do a barium swallow, and that too you have to take a lateral phlegm. Okay, so you have to take a lateral phlegm in these particular patients. So a lateral phlegm, barium swallow, this is what is your investigation of choice in order to diagnose your Zenkus diverticulum. Now this is how your barium swallow will look like. I hope you're able to appreciate over here. This is what is your diverticulum. Okay, so this is lateral phlegm of the neck, and this is what is your diverticulum outpouching from this particular esophagus, and this is what is referred to as your Zenkus diverticulum. Okay, I hope you got this particular point. Very important. Okay, I hope you got this point. Now let's talk about the treatment. So how will you manage these particular patients? So if at all you have a large diverticulum, you have to go in for a diverticulectomy. You have to go in for a diverticulectomy. But if at all, let's say okay, so yeah, we have to go in for a diverticulectomy. Now before I proceed forward and I tell you about something else, can you please tell me what is this? So there is something which is called as a Dolman's procedure. So can you please tell me, guys, this Dolman's procedure is done for what? Can you please tell me? Can you please explain it to me? So is it done for your rectal prolapse? Is it done for your esophageal achalasia? Is it done for your carcinoma esophagus, or is it done for your Zenkus diverticulum? So yeah, can you please tell me, guys, this is basically done for what? So guys, please understand, your Dolman's procedure, this is basically done for your Zenkus diverticulum. Okay, so what is this Dolman's procedure, guys? What is this Dolman's procedure? This Dolman's procedure is basically your endoscopic diverticulopexy. Now what you basically do in this, you have a endoscopic stapler. So what do you have? You have an endoscopic stapler, and this endoscopic stapler, it is having two ends. Like the end is basically divided like this. So as you can see over here, what is going to happen? One of these particular ends, okay, so one of these particular ends is going to kind of go into the lumen. The one of these ends is going to go into the lumen, and the another end is basically going to go into the diverticulum. I'll just kind of move apart so that you can appreciate this properly. As you can see over here, one of these ends is kind of going into the lumen, but the other end is kind of going into the diverticulum. So one of these ends is in the lumen, one of the ends is in the diverticulum. And when you fire the stapler, okay, when you fire the stapler, what is going to happen? Earlier you had a diverticulum like this, okay? Earlier you had a diverticulum like this. Now what you have? You have an endoscopic stapler with one end in the lumen, one in the diverticulum. When you fire the stapler, firing stapler, what is going to happen? The wall in the diverticulum is kind of going to go down. And now what is going to happen? The food will not kind of get obstructed over here. Food is going to go down, and all those things, the halitosis, the bad odor, the lung abscess, all those things which are happening, that is not going to happen. So this is what you need to understand regarding the Dolman procedure. Now where do you do this? Do you do this in every patient? So no. If at all the patient is having a lot of comorbidities, okay, if at all there are comorbidities in the patient, then you basically prefer the patient to have this particular Dolman procedure. Okay, I hope you get this particular point. Now let's move on and let's talk about the next question for you guys today. So what is the next question? Best investigation to look for T and N stage of the tumor. So let's say you have a esophageal carcinoma. What I'm trying to ask you is that what is the best investigation to look for your T and N stage of the tumor? So what is the answer over here, guys? Is it like your endoscopic biopsy? Is it your endoscopic USG? Is it your CCT or an MRI? What do you think, guys? What is the answer over here? Now please understand, the answer over here is an endoscopic USG. An endoscopic USG is the best investigation to look for T and N stage of the tumor. Now what is this endoscopic USG, guys? What is this endoscopic USG? So please understand, this is how an endoscopic USG looks like. Okay, so this is an image of an endoscopic USG. This is what is called as EUS, endoscopic USG. Now what are you doing in this endoscopic USG, guys? So as you can see over here, this is the mouth of the patient and everything. What you're basically doing over here, your endoscope is being passed from the mouth, it is going to the esophagus, and at the end of the endoscope, what are you having? At the end of the endoscope, you have your camera attached, or you have your USG probe which is attached over here. Okay, so at the end of the scope you have a USG probe which is attached over here, and because of this USG probe, what is happening, it is taking a radial USG. Okay, so it is basically taking this USG probe is doing its job. It is basically taking the USG, and you are getting this particular image. The only thing is this image is present in the lower part of the esophagus. This is what you call it as an endoscopic USG. Now please mark my words, this is very important point. This EUS is an investigation of choice for the T and N stage, not only in the esophageal carcinoma but also for your gastric carcinoma. So this is an investigation of choice for the T and N stage in your esophageal and gastric carcinoma. Okay, in the esophageal and the gastric carcinoma, this EUS is a investigation of choice to look for the T and N stage. Okay, if somebody asks you what is the investigation of choice for overall staging of the esophageal carcinoma, the answer is PET CT or a CCT. Okay, that is the kind of investigation of choice for the overall staging of the your esophageal carcinoma. Okay, I hope you're able to understand this. Now what are these guys? So are you able to appreciate that here there is a concentric white and the black rings which you're seeing over here? I hope you're able to appreciate that there are concentric white and the black rings which you're basically seeing in this endoscopic USG. Now what are these concentric white and the black rings, guys? This is what looks like. Okay, this is what it indicates. Now this is important because this is given in your 11 billy and you should be aware of this particular point. Okay, so what you need to understand, if you want to remember just what is going to be asked to you, just remember that this muscularis mucosa and the muscularis propria, that is the layers which are containing the muscle, they are appearing black. Okay, are you able to understand this point? So they are the ones which are appearing black, but the mucosa, the submucosa and the serosa. Okay, so the mucosa, the submucosa, and here in the below it's basically the serosa. These are the three layers which are appearing white. Are you able to understand this point? So it's a concentric arrangement of a white black layers. What you need to understand, your muscularis mucosa, which is your second layer, and the muscularis propria, which is your fourth layer, they are appearing black. On the other hand, your mucosa, your submucosa and your serosa, mucosa, submucosa and the serosa, which are your 1, 3 and 5th layer, they are basically appearing white on the USG, guys. Okay, so they are basically hyperintense. I hope you get this particular point, guys. Okay, now this is something which is important, and please remember this can be asked to you. Now moving on to the next question for you guys. So treatment of choice for the malignant tracheoesophageal fistula. So if you have a malignant tracheoesophageal fistula, now first and foremost, what do you mean by a malignant tracheoesophageal fistula, guys? Okay, what do you mean by a malignant tracheoesophageal fistula? Please understand, let's say there is a carcinomatous growth in the esophagus. This particular growth has a propensity to grow, and it has a propensity to erode through this particular esophagus and erode into your trachea. It has a propensity for that. Okay, now if at all there is a growth which is occurring in the esophagus, so let's say there is a growth which is occurring in the esophagus, this tumor grows and it basically enters into the trachea. What is going to happen? There is going to be a fistulous communication between the esophagus and the trachea. So this is what is referred to as a malignant tracheoesophageal fistula. I hope you are able to understand this point. Now if at all I ask you what is the treatment of choice for the malignant tracheoesophageal fistula, what is the answer, guys? Is it like a surgical excision, SEMS, radiotherapy, or the feeding jejunostomy? What do you think, guys? What is the answer over here? Now if you answer that the answer to this particular question is SEMS, You are absolutely correct, guys. Okay, so please understand what is the kind of a treatment of choice for your malignant tracheal fistula. The answer is SEMS. What is this SEMS, guys? SEMS basically stands for your self-expandable metallic stents. Are you able to understand this point? So these self-expandable metallic stents can also be used for the palliative procedure. So no doubt these SEMS, that self-expandable metallic stents, can be used as a palliative procedure in the metastatic carcinoma esophagus. Yes, they can be used, and these SEMS, they are either covered or they are uncovered. Now, as you can see, these are the covered. Yeah, this particular image which you're basically seeing over here, this is covered, right? So this is covered. So these covered self-expandable metallic stents are the ones which are basically used for your malignant tracheal fistula. Are you able to understand this point? So if at all you put these covered SEMS, covered self-expandable metallic stents, this is what is your treatment of choice for your malignant tracheoesophageal fistula. Okay, I hope you get this particular point. Okay, I hope you get this point. Okay, so covered self-expandable metallic stents, these are the treatment of choice for your malignant tracheal fistula. At the same time, I'll just cover this point. So I've already told you, but I'll just write it over here. SEMS are also used as a palliative treatment, for what? They're also used as a palliative treatment in places of your metastatic carcinoma of the esophagus. Okay, in the metastatic carcinoma of the esophagus, they are also used as a palliative treatment. Okay, I hope you get this particular point. Now moving on, guys. Now, which of the following statements about the leiomyoma of the esophagus is false? So leiomyoma, a benign tumor of the esophagus, which of these following statements is false? I'll just go away so that you can kind of have a look at this particular question. So it is kind of the most common benign tumor of the esophagus. On barium swallow, it shows a well kind of demarcated lesion. FNAC is done to diagnose this particular condition, and enucleation is the treatment of choice. So what do you think, guys? What is your opinion? What do you think? Is this particular thing right, wrong? What exactly is this, guys? So please understand, the answer to this particular question is FNAC. Do you do an FNAC for your carcinoma, for your leiomyoma? The answer is no. We do not do an FNAC for the leiomyoma. Now first, let us understand what is this leiomyoma. Okay, what is this leiomyoma? Leiomyoma is basically your benign, like the most common benign tumor of your esophagus. So what is this? This is your leiomyoma. Okay, so what is this? This is a leiomyoma. This is basically the most common benign tumor of your esophagus, and as you can see, this is in EUS, that is endoscopic USG, and you're able to see this well demarcated circular homogeneous lesion. This is basically indicative that this is a leiomyoma. Okay, I hope you get this point. And yeah, this is basically in the black layer, so it indicating that it is muscular in origin. Now what you need to appreciate is that, okay, this is a benign tumor of the esophagus and all those stuff is fine, but the treatment of this particular condition is, what is the treatment for your leiomyoma, guys? The treatment for the leiomyoma is enucleation. Okay, it is enucleation. Now what do you mean by enucleation, guys? Enucleation basically means that, as you can see, there is a capsule kind of a thing which is kind of present around this leiomyoma. So what is going to happen? There is, let's say, leiomyomatous tumor over here. So what you basically do, you just enucleate it out. Okay, so you basically just cut this particular capsule a bit, and then you just scoop out this particular leiomyoma out of it. Okay, so you just scoop out this particular leiomyoma out of it. So you just enucleate the leiomyoma. Okay, are you able to understand this point? So it is basically you just take this particular leiomyoma out by enucleation. But if at all you go in for an FNAC, okay, if at all you do go in for an FNAC, if FNAC is done, what is going to happen? Let's say you do an FNAC over here. What is going to happen? After the FNAC, like post procedure, post FNAC, what is going to happen? This capsule of your leiomyoma, okay, so what is going to happen? The capsule which you have for the leiomyoma, it is going to be adhered to this leiomyoma from the place where you have taken this FNAC sample. Okay, so there is going to be adherence of the capsule where you have taken this FNAC sample, and after you have done the FNAC, enucleation will be difficult. Enucleation is difficult. So that is why FNAC is kind of not preferred. Just by looking at the gross examination and the EUS, you can make the diagnosis of a leiomyoma and you just go in for an enucleation. FNAC is not done. The reason for this, why FNAC is not done, because the capsule can be adhered at that particular point, and if at all the capsule is adhered, it will be difficult for you to enucleate this particular tumor out. Okay, I hope you get this particular point. Okay, so it was a pretty simple question, but yeah, you need to understand that enucleation is something which is not preferred in these particular patients. Okay, I'm really sorry, I just come back. So yeah, POEMS. What is this particular poem? POEMS is basically a treatment option for what? Like, is it a treatment option for your GERD, for achalasia cardia, for the leiomyoma of the esophagus, or for the Barrett's esophagus? Now guys, this has already been asked to you, and yeah, I'll just wait. What is the answer to this particular question, guys? POEMS procedure is done for. So definitely the answer is achalasia cardia. Where do you go in for a POEMS procedure? So POEMS procedure is something which is preferred for your achalasia cardia. Now, what is this POEMS procedure, guys? What is this particular POEMS procedure? POEMS procedure basically stands for your, POEM basically stands for your per oral endoscopic myectomy. So this has already been asked, guys, and I'm sure 99% of you guys must be knowing this. So this is what is your per oral endoscopic myectomy. So what you're basically doing, you're going through a per oral route and you are resecting that particular muscle layer. That is what is a POEMS procedure. Now, before we talk about the POEMS procedure any further, if I just ask you, what is the treatment of choice for achalasia cardia? Okay, so what is the treatment of choice for the achalasia? It is Heller's cardiomyotomy. Okay, it is Heller's cardiomyotomy. That is what is your treatment of choice for your achalasia cardia. Are you able to understand this point? Heller's cardiomyotomy, that is the treatment of choice for your achalasia cardia. But now we are coming up with this endoscopic procedure, which is POEM. What exactly you doing over here, guys? So as you can appreciate that your endoscope is kind of coming over here. It is kind of cutting this particular mucosa and it is entering into the submucosal layer, and then it is kind of cutting this particular muscle layer out. Are you able to appreciate it, guys? So this is what is called as a POEMS procedure, per oral endoscopic myectomy. You're cutting the muscle via the endoscopic route by cutting the mucosa, entering into the muscle layer, and then you're kind of cutting it off. Are you able to understand this point? This is what is called as a POEMS procedure or a per oral endoscopic myectomy. Okay, understood this particular point, guys? Yeah, I hope you got this particular point. Right now, yeah, now let's move on to the next question, guys. So false about the Schottky's ring. So I'll just go away. Can you please tell me, guys, what is false about the Schottky's ring, guys? It occurs in the lower part of the esophagus, involves the mucosa and the submucosa, involves the mucosa, submucosa, and the muscularis, or located in the squamocolumnar junction. Which of these is a false statement regarding the Schottky's ring? Now, if you're thinking, if and only if you're thinking that the answer to this particular question is C, you are absolutely correct. Okay, so what do you think? The answer to this particular question is, it doesn't have a muscularis layer. Okay, it doesn't have muscularis, it has only the mucosa and the submucosa. Now what I'll do, I'll just walk you through these esophageal rings. Okay, so I'll just walk you through the concept of the esophageal ring. Now what do you need to understand? We have three types of the esophageal ring. Okay, how many types? We have three types of the esophageal ring. We have A types, and then we have B type, and we have your kind of C type. Okay, and then there is C type also. That's fine. So we have three types of the esophageal ring, but the most important one is this Schottky's ring. Okay, so the Schottky's ring is something which is important. Now the cause of this Schottky's ring is your GERD. What is the cause of your Schottky's ring? The cause is basically, the proposed cause for this is your GERD. Now what is happening because of this? There is a mucosal and the submucosal ring. So this Schottky's ring or the type B ring, this is what is your consisting of the mucosa and submucosa. Where it is forming? So this is basically forming at the squamocolumnar junction, junction. So you are basically getting this Schottky's ring at this squamocolumnar junction. Are you able to appreciate it, guys? Now important point is, how do you treat it? So let's say if at all you have a Schottky's ring, how will you manage this particular kind of condition, guys? So what will be the treatment? How will you manage this Schottky's ring? What will be the treatment? Now please understand, you will not go in for an excision. Okay, what about the excision? It is not an option, because if you prefer to go in for an excision, what is going to happen? There is going to be stenosis. Okay, so there is going to be a post-procedure stenosis. That is why you will not go in for an excision. For the treatment, what you prefer to go in for, you just prefer to go in for a dilation. So you basically just dilate these particular rings. You do not prefer to go in for an excision. Are you able to appreciate it, guys? So well, this is all about what I think I wish to cover. Okay, I have one more thing. Okay, I have okay, this is basically all about what we kind of wish to cover today, guys. Now what I'll do, I'll just concise whatever I have like a couple of minutes more, so I'll just concise whatever we have read today so that it kind of forms a base in your mind. I'll just kind of quickly concise whatever we have covered today, and then I'll be kind of sharing some things with you. So please be here, guys. So first we talked in detail about your Zenkus Diabetic. Okay, so what did we talk about? We talked about the Zenkus Diabetic in detail. Now what is the Zenkus Diabetic, guys? We have an inferior constrictor muscle. This is basically consisting of your thyropharyngeus and the cricopharyngeus. Now these are basically, these two people are kind of working in the same office, that is your inferior constrictor, but they're receiving the nerve supply from two different bosses. So obviously there is going to be a neuromuscular incoordination. If at all there is a neuromuscular incoordination, what is going to happen? The mucosa is going to pop out of it, and if at all the mucosa pops out, it comes out to as a kind of your Zenkus Diabetic. Now from which is the place from which it basically pops out? So it basically pops out from your Killian's triangle. Now the question which I had asked you, it is not arising anteriorly, it is arising posteriorly. As you can see in this particular figure also, it is arising posterior to this particular inferior constrictor muscle or something like that. Okay, I hope you got this point. Now yeah, that is the pathogenesis, all done. Now what is happening? The food is basically going and it is getting accumulated in this particular diverticulum. Because of this, there is a partial degeneration, degradation of this food. Patient gets halitosis, there is regurgitation, there is lung abscess, pneumonitis, all those stuff. Investigation of choice, you go in for a barium swallow, but you have to go in for a lateral film. Okay, so lateral film barium swallow, that is what is your investigation of choice for this. Now for the treatment, if at all, let's say there is a large diverticulum, you go in for a diverticulectomy. But let's say if at all the patient is having a lot of comorbidity, then what you'll do, you will have a stapler. This stapler is basically put inside. One of these particular arms is going into the kind of your diverticulum, another arm is basically staying in the lumen. You fire it, and whatever the wall is present between, it is kind of taken off. So if at all this particular wall is taken off, you have no symptoms. So food is going to come, it is going to go down, it is not going to stay there, it is not going to cause any of the symptoms. What is this called as? This is what is called as a Dollmann's procedure. Okay, what is this called as? It is called as a Dollmann's procedure. Then we kind of moved and talked about your endoscopic USG. I told you that this is the investigation of choice for the T and N stage in the esophageal and the gastric carcinoma. I explained you that there are 5 layers which you get. So we get white, black, and white. So out of this, the muscularis mucosa and the muscularis propria, these are the two which are kind of black. Others like the mucosa, the submucosa, and your serosa, these are the having high intensity, that is they appear white. We talked about the endoscopic USG. Then what did I tell you? That okay, what is the treatment for the malignant tracheal fistula? So we go in for a covered self-expandable metallic stents. Now what are these self-expandable metallic stents? These can also be used as a palliative procedure if at all, let's say there is a patient with a metastatic carcinoma esophagus. We cannot do anything, right? This patient is going to die in the next 6 months. All we can do is make the stay of this particular patient for whatever months he's kind of be with us, we can make that particular stay a bit symptom free. And what we can do, we can just give him SEMS, that is self-expandable metallic stents. Right, great. Then we've talked about leiomyoma. So it is basically a simple benign tumor. All you need to understand is that in order to diagnose it, we do not need to go in for an FNAC. Why? Because the treatment is enucleation. If you go in for an FNAC, the capsule, like the mucosa, the capsule, whatever, it is going to get adherent to this particular leiomyoma, and it will be very difficult to enucleate it out. And that is why we do not go in for an FNAC. Yeah, we do not go in for an FNAC, right? Then what I talked to you about was a Pawan procedure. What is this Pawan procedure? This is something which is basically used for your achalasia cardia. What you basically do in this, you go down, you kind of cut your mucosa, you go into this, and you kind of cut your muscle there. So this is what is a Pawan procedure. This is something like a Hellas cardiomyotomy, but it is non-invasively, like yeah, minimally non-invasively. You're just going in upper GI endoscopy, so that's fine. Minimally invasively. Right, I hope you get this point. Then we talked about the Schottky's ring. This is basically a simple ring which is consisting of the mucosa and the submucosa and the squamocolumnar junction. That is all you need to understand. The cause, proposed cause is the GERD, that is fine. And the treatment, how do you manage these particular patients? So treatment of this kind of Schottky's ring, it is not an excision, we have to go in for a dilation. So that's it, guys. That's all I wish to cover with you guys today. Thank you so much. It was indeed a pleasure interacting with you. Before you go, please give it a thumbs up and please kind of subscribe and please share it, guys, within your groups or something. If at all you like this particular session, I have planned 8 sessions for this particular month. This is the second session. You can check it out, the first episode 1, in which we have covered the sutures value topic. At the same time, guys, I hope that you know that I am also a plus educator on this Unacademy platform, and there are various courses which are coming up. We are coming up with that's already running, guys. Okay, so there's already a focused NEET PG 2020 batch, 2021 batch, which will definitely be helpful for you if at all you are kind of looking for a source to revise with you guys or something like that. So I will be taking up your surgery revisions over there. If you wish, you can definitely join along with me. Obviously, there are many other great educators. You can definitely have a kind of taste of them if at all you want to take a subscription. If at all you wish to take a subscription, please do consider using my promo code. My promo code is dr.pawan. And yeah, please guys, I mean, you can download the app and please refer it, because there are also many special classes which are kind of conducted free and all those stuff. So yeah, you can kind of experience them. Thank you so much. It was indeed a pleasure interacting with you. Have a great day. Happy studying. See you soon. See you tomorrow, same time, 6 p.m. We'll be coming with the episode 3. I think we'll be talking about stomach tomorrow, I guess. But yeah, see you tomorrow, guys. Okay. Have a great day. See you. Bye. Happy studying. Love you.